Yeah, kind of an interesting topic here, 30 minutes of all you ever wanted to know about urine but were afraid to ask. So let's talk about this. Really the issues are regarding what's the best test for urinalysis in pediatrics, what do these tests mean, when can we do the shortcut, maybe do a bagged urine as opposed to a suprapubic aspiration or a cath, what's important to us and how can we get the right answers. So let's jump right in. We got a bunch of abstracts, but I'm going to summarize a lot of this for you. What is the most common cause of serious bacterial illness in febrile children? Knowing that we have really changed the architecture and the landscape here based on our current vaccination status. With Hib as well as with Pneumovax, we know that the most likely source of infection in febrile infants is what? It's the urinary tract by far. So abstract number 1, they looked at 449 neonates, 28 days or less, so very important to us. Temperature of 38 or greater, and serious bacterial infections were noted in 19.4%, 24% in males, 11% for females. So what we should realize is have a higher index of suspicion for the males than the females, particularly if the males are uncircumcised, very important. The rates particularly decreased after 8 days when most of these kids have been circumcised after that point. So very important. Low-risk criterion that they developed, if they weren't ill-appearing, but I would caution even the most seasoned pediatrician that under 28 days, most of the literature says you can look at them, you think they look perfect, and you can't tell. It's kind of like testicular torsion. If you look at the data on this, there are a lot of docs out there that say, you know, I've been doing this for years. I can sort out epididymitis versus torsion on a physical examination. And my response to them is, well, do you have extra experience doing this? I mean, well, I do this all the time. I said, well, keep your personal life out of this. But how can you sort these out? You can't sort those two out. And when you get to the very young infants, you know, 28 days, the neonates, nobody can sort them out. And probably for the rest of us who don't see peds full time, I would probably extend that further to up to maybe 60 or 90 days where we think we can look at them and they look good to us, but do we really know? Well, let's take a look at the low-risk criteria. Non-ill appearing, white cell count between 5,000 and 15,000. I'm hoping you'll never have the test to apply this. Urine dip negative for leukocyte esterase, and fewer than 23 white cells per high power field in the CSF. I love that one. So if they're not ill appearing and their white cells have not gone above 23 on the LP, they're probably in a low risk category. Why would you be tapping the low risk ones? So that was kind of interesting. Here's an important takeaway point from this abstract though. Ill appearance, the sensitivity for serious bacterial infection was 21%. So this really confirms what I just mentioned to you, that you can't differentiate torsion from epididymitis. Nah, I'm just kidding you. You can't take a look at these little kids and say, I've done this all day, every day for 20 years. I can tell which are sick and which are not. You just can't do it. All right, abstract number 2, 429 febrile infants, aged from 57 to 180 days. 44 children had serious bacterial infections. That was 10.5%. Blood cultures were only positive in 4, less than a percent, 0.9%. Urine cultures were positive about 10% though. So again, that speaks to the concept that we need to be looking to the urine. Now we're looking at kids without a source. What can we attribute their symptoms to as a source? I get this question a lot from our physicians. If you look at the data, there are really a couple things we can't attribute it to. What about if they have upper respiratory symptoms? They've got a little bit of sniffles, runny nose, cough. Can we say, oh great, since you have a viral upper respiratory infection, you will not have a serious bacterial infection? Is that reasonable? That is not a reasonable and legitimate source. And it really speaks to that here. Viral swabs, 4.9% of them with the patients who had serious bacterial infections had a positive viral swab. And I will extend this further to RSV. There's good literature to say too, it's about the same percentage of kids will have a serious bacterial infection. It will almost always be a urinary tract infection when they have RSV also. All right, and ill-appearing, 10% were not ill-appearing in the kids that had a serious bacterial infection. So again, you're going to miss these kids. And this was 57 to 180 days, not less than 28 days. So even 10% of these didn't look sick to people, and they were sick. All right, urine cultures, 9.7% were positive in females, 36% were positive in the uncircumcised males, and 1.6% were positive in the circumcised males. So again, your index of suspicion should skyrocket in the uncircumcised male. Abstract number 3, looking at post-pneumococcal vaccine era, looking at the 3 to 36-month age range. UTI should be the focus. No blood cultures, they don't need them, and no empiric antibiotics. Look to the urine. And if you're concerned because they have other physical findings that worry you, well then do the septic workup. We're not saying never do it. If they look toxic, they're not really responding to the parents. Whatever it is that worries you, if the parents are worried or you're worried, do the test. You know, most of the tests we do for a septic workup are really pretty safe. I hear this a lot from docs who don't really like to do LPs. They're like, wow, that's a scary procedure. We should be doing less of them for headaches and everything else because it's dangerous. Do you think an LP is dangerous in any age group? It's really not. It's actually safer statistically than IV starts, less complication rate. All right, then the next question. What are some of the challenges of urinary collection in small children? This is a very short question here. We'll answer it. They said a couple things. First of all, sometimes you're not prepared to collect the urine. Have the cup with you and the cap off it, because anyone who's been a parent here understands when you don't expect it, that's when you should expect it, and oftentimes you'll get christened, as Al Sacchetti put it in this chapter, and you'll get sprayed with it. Anybody here been hit with urine from a family member? It happens. Changing a diaper, and whoa, there it goes. You've got to learn how to dodge that stuff. But if you were in the ED, it would be great if you could just try and get under that and get a few cc's. It would help you. All right, are there any physical techniques to facilitate spontaneous urination in a child? This is where I learned a few things, and it's got really interesting in this part of the discussion, and it freaked me out a little bit too. But let's see if you've done this. We'll take a show of hands in a moment and see if you're willing to do it. This, if you look at abstract number 4, reduction of mixed growth rates in the urine after using the finger tap method. So we're going to use the finger tap to stimulate urination. So what they did was they tapped the child's abdomen just above the symphysis pubis, and they waited with the cup with the cap off. Go. If not, I'll just tap you a little bit more. Maybe a little scratch will work. Maybe a little tickle of the umbilicus. I'm not sure what works, but apparently there are some investigators, and these included, feel like that's probably going to stimulate some urine flow, so just be ready for it. I wouldn't recommend this in adults. It gets kind of really weird then. You know, sir, do you want a catheter, or do you want me to just tap on your bladder? Well, let's try the bladder tap thing. You might get some results you really were not expecting at all. I would just avoid that altogether. But let's take a look at what they found regarding contamination rate, because they also looked at if you cleanse the area. The washed genitalia bag specimen, 51% contamination rate. You know, some of these abstracts actually suggest that with all of our manipulation of the area with trying to clean the periurethral area, we're actually making more contamination than we are preventing it. Finger tap unwashed genitalia, 13.2%, but the finger tap with the washed genitalia, 7.7%. This is like when you go through the car wash. Do you want the undercarriage wash and the spot-free rinse? Yes, I'll take the tapping with the cleansing, please. Hit the gold wash, and you'll get all of that, I guess. All right, can urine collected in diapers be used for evaluation? I love this one. I never thought about this. Has anyone ever taken a diaper off and wrung out the urine and said, let's just send it and see what happens? That's what they're saying here, and it's pretty cool. I will do this. But they really cautioned you that, you know, the newer, really cool space-age diapers that have like the polystyrene little balls in it that are really super absorbent, it really messes things up. You can't really use those. So you need the fibrous type of diapers. The ones that they fill up and they're just kind of hanging off the back. You've seen them. It's time to change the diaper. Abstract number 5, 45 infants, 1 to 23 months, bag versus extraction from a wet diaper. There were a few qualifications here. There could be no little presence in the diaper. No feces there. That kind of makes sense. And the diaper could not be worn more than 4 hours. That's just bad parenting. You got to have a little clock on the diaper. I mean, I don't know. When my kids were in diapers, even if they didn't need a change, you've had this diaper on all day. Let's just go ahead and change it either way. 4 hours is a long time. Here was the interesting part, too. 11 children aged 10 to 14. The biggest concern and question is how they get them to wear the diaper. Now, if you read on a little bit, what they actually did was got their urine and they poured it in the diaper. They couldn't get them to wear the diaper. They poured it in the diaper and compared. There was actually 82% agreement between the wrung-out diaper and the specimen they obtained just by a bagger. And these kids, again, they didn't bag these older kids 10 to 14. But the white cell count and the red cell count when you extract it from a diaper is going to be less. You just have to be aware of that. Abstract 6 found the same thing. They looked at 38 kids less than 2 years. He did a cath or suprapubic aspiration versus the diaper extraction. And just to give you a sense of how to do this, you take a bunch of fibers with a 20 cc syringe. You wear a glove. Okay, wear a glove. And tear the fibers out that are soaked. Stick them in the syringe. And then you put the plunger in. You kind of squeeze the urine out that way. And they're saying it works pretty well. Don't aim the syringe anywhere you don't want it to go. right, positive cultures in 5 out of 38 for a cath, and also those were culture positive from the diaper. What the issue was, the cultures were pretty good, but the white blood cell count were 40 to 70% lower on the urine extracted from the diaper. And 2 cases were positive in the diaper but negative for either cath or suprapubic aspiration, so those were really false positives. Sensitivity 100%, specificity was 94%. That was a pretty good screening tool. I know the nurses would think you're freaking crazy if you do this. I got to do this just for the shock factor. Do you want me to bag them? No, I don't like bags, so let's not do the bagging. Can you use bagging? Yeah, to screen them, maybe perhaps, but if you want the right test to confirm it, maybe we'll go right to the right test. But if you have to take no effort at all, well, the diaper's pretty soaked, so they probably won't go right away. We're going to have to wait a while. Hey, don't throw the diaper out. Let's send it. I'm waiting to get that response. All right, how accurate are midstream urine specimens? They're pretty accurate, but we'll summarize abstracts 7 through 12. Number 7 from University of Virginia looked at 102 healthy females. They did urethral meatus cleaning prior to midstream collection, and they used the reverse sitting position, which I guess was better to expose the area to decrease contamination. 98% with or without cleansing in the initial collection or in the midstream yielded no growth. So they did pretty well with that. All right, number 8, 102 circumcised males aged 2 to 14. They found 10% contamination rate in the cleansed specimens, but 5% contamination rate in the uncleansed specimen. So they said no benefit of cleansing. I don't think we can go the other direction necessarily, say cleansing is bad, but does this raise the question and the argument, does it really help that much? Maybe it doesn't. Number 9, the important thing here is they looked at 60 circumcised males, 1 to 21 weeks, midstream collections compared with suprapubic aspirations, and almost all the cultures matched perfectly. So that was good news. So the midstream actually worked pretty well. Number 10 is the bonus abstract. If I'm not mistaken, it's the same as abstract number 7. And number 11 we'll skip to 350 toilet-trained children, 2 to 18. I'm glad they selected the toilet-trained 15 to 18-year-olds. I'm glad they selected those. The others would be a little bit strange to put into a study. In this study, the contamination rate was 15.3% in those without genitalia cleansing, but 10.3% with those with cleansing in the children 2 to 5 years of age. So this says cleansing probably does provide some value. And then finally, abstract number 12, they talked about non-cleanse catch urine in infants compared to suprapubic aspiration in 58 infants. And what they found is 18 of the suprapubic aspirations were positive, but the clean catch only picked up 16 of those. So the sensitivity dropped down to 89%. They said, really, maybe it's not as good, and maybe this favors suprapubic aspiration. You know, as much as the literature says suprapubic aspiration is really safe, how many of us just feel like routinely saying, you know, we can't get a cath, let's bring a needle in there and stick it into their bladder? I think parents are going to freak out with that. How about the pediatric EM docs here? I mean, do parents freak out with that? I mean, I think they understand the catheter, they're into that, but I tell you, suprapubic, I don't know that we always need to go there. All right, and the interesting thing is, if you are going to go that direction, ultrasound guidance got them there 93% of the time on the first attempt, only 62% of the time without ultrasound guidance. So if you're going to do this, you probably should use ultrasound guidance. So where do bag urine specimens fit into pediatric evaluations? Look at the next set of abstracts, 13 through 18. Here's the nutshell. You can use these if you want to screen for UTI in those who you're not really worried about, not the febrile neonate at 28 days. But if you just want to screen for UTI, you can. But if you need to confirm it, then the bag isn't good enough. So you have to decide which philosophy you believe in. Can we screen these and we don't have to do a lot of testing in the rest of them? Or do we screen these and then we have to do additional testing in order to urinalysis anyway? My feeling is I would move right toward, let me get the test that's going to get me the answer and I'll be done at that point. And so I don't do a lot of bagged urines. But I'm going to do the diaper thing. No, I got to try that. All right, number 13. They looked at 90 male infants and children. Majority, 98% of them were below 1 year of age, and most of them were circumcised. All were cleaned with soap prior to the placement of the bag. All of them had normal UAs and cultures. They didn't expect these kids to be sick. They were trying to look for normals and see if there were contaminants, and they didn't find any. Abstract 14, 303 kids less than 3 years of age. Almost 20% of these were less than 3 months. 33% of them were boys, and of all comers, 27.1% were positive, had positive cultures. What was interesting here is the sensitivity for for nitrate leukocyte esterase as well as for urinalysis and the dip, they reported here was actually better for the bag than it really was for even the cath. But the issue is the specificities were horrible, so you're getting a lot of false positives. So again, how many repeat tests do you want to do? How many unnecessary doses of antibiotics do you want to write for? All right, this additional abstract here, under 14, urine culture from bag specimens in young children. It's unnumbered, but it's really good. They screened with bag specimens, and the contamination rate was 62.8%. That is huge. Another reason to tell us maybe we don't want to do this. And the best reason, I think this may be one of the best articles listed in this whole chapter, are the odds ratios for further workup. So what is basically an odds ratio? Very much like a likelihood ratio. An odds ratio of 1 is basically the same likelihood that the people in the group you're looking at and the people outside the group you're looking at are going to have the same event. So we're saying here, for instance, an unnecessary recall of a patient to come back to the hospital, 4.9 in those who are going to have a contaminant than those who wouldn't with the bag specimen. So 4.9 times more likely to call them back for a repeat test. Unnecessary treatment, 4.8. Inappropriate prolonged treatment, 15.6. Unnecessary radiology investigation, 4.1. Unnecessary hospital admission, 12.4. It's huge. An admission for a false positive bagged urine, bad idea. And then delayed diagnosis and treatment, they said the odds ratio was infinite. The number was huge. So with those numbers, is it worth it for you to bag these kids? My feeling is it probably is not. Okay, abstract number 15. They looked at bag methods and urethral catheterization in 192 febrile children, and these are the ones we're most concerned about, the febrile ones. And the bag specimens had culture positive 48.4% and 53.2% in the cath, but here is the take-home message here. So in the bag specimens, 7.5% of these were false positives, and nearly 30% were false negatives. So did it really get you any further? It got you a lot further to the wrong answer. So again, I don't think bags are really the way to go. All right, 16, cath and clean catch comparison. 98 children less than 2 years of age, 83% were uncircumcised. They had no fever, no signs of urinary tract infection. 100% had negative cultures, and they confirmed this because they were at the urology office and they were going to have cystourethropy. So when they were doing the cysto, they got the definitive gold standard culture they were looking for. False positive rate in boys, similar for both techniques, 66% in the cath, 88% in the clean catch, but it was all mixed flora. What that's telling us is if you're a little bit intuitive when you look at the culture result when it comes back, you can say it's probably not a staph epidermidis urinary tract infection, right? It doesn't make sense. And in the girls, less contamination rate, 12%. For the cath, 69% for the clean catch. But in none of these cases, none of them did the colony counts rise to the level where you would be able to call it a UTI. So therefore, you'd say they're contaminants. So from that perspective, you can say, hey, you know, maybe the comparison's okay there. All right, 17, one of the big issues there, it just really confirms for us that the contaminants that we do get are really from the periurethral area. They looked at bag urines, 98 healthy newborns. Urinary pathogens were discovered in 21 of them. 16 of the 21 had high enough colony counts for them to say, wait a minute, it's high enough, I can call it a UTI, so therefore they were false positives, and somebody might go ahead and treat that. 0 of these were found in circumcised males. The author states, well, if you want to do a cath or a suprapubic aspiration, yeah, you can do that for those who are maybe uncircumcised and you need to go that direction. Otherwise, you may not need to go that way. Number 18, very interesting with our pediatric colleagues. American Academy of Pediatrics discourages the use of bagged urines. But what do the pediatricians do in the office? They do bagged urines. 219 office pediatricians treating over 3,000 febrile children 0 to 3 months, febrile. And the catheter collection was performed in 69%, bag collection in 24%, positive culture similar in both groups, 8 versus 11%. But they're not really following their own recommendation. Is it a surprise that sometimes when we make a phone call and talk to the pediatrician and say, listen, I've got a 35-day-old with a fever, I don't have a source, and I'm doing these tests, they might say, well, you don't need to do an LP on them. Or you've done the LP, or you've done these things, maybe they can just be seen in the office tomorrow. Because they are taking certainly an approach that's less aggressive than we take in the ED many times. Okay, so what's the best invasive means to collect a urine specimen? Abstract number 19. It's really up to you, but they say suprapubic, 46% success rate, requires 17 seconds. I think you've got to be pretty good at this to do it in 17 seconds. compared to a 100% success rate for urinary catheterization, and it's 81 seconds. I'll take the extra minute and have the nurses get the urinary catheter. I think it's fine. All right, is there anything to be done to relieve the pain for urethral catheterization? Yeah, there is, and this is kind of an interesting article. Abstract 20, they looked at 20 children aged 4 to 11, so at least they could report pain. It was double-blinded at the Pediatric Urology clinic. They did lidocaine lubricant versus chlorhexidine jelly. And first they used a cotton ball soaked on the meatus for 1 to 2 minutes. Okay. I don't know if they taped it or someone held it there. That's a whole logistics issue I don't think we need to get into. But then a half cc to 2 cc's of lubricant, either the control lubricant, the chlorhexidine, or the lidocaine, it was instilled in the urethra 3 times with 2 minutes in between each application. How many patients could you have discharged in that time frame in the emergency department? I don't think I could do this. But, you know, the interesting thing is if somebody's really worried and concerned, their pain score, they looked at a pain score of 0 to 100. The placebo or the chlorhexidine group had a pain rating of 66 with the catheterization, 21 with the lidocaine. So they said it was less painful. I don't doubt that it's less painful, but is it really practical for us to do it that way? In the Pediatric Urology clinic, they probably line them up in a line. Okay, here's your cotton ball. Everybody put their cotton ball on, and then they go and they, maybe you can do this in assembly line sort of thing, but on a case-by-case basis, probably not that effective. All right, can the presence of parents reduce the stress of urethral catheterizations? Abstracts 21 through 24. What we know it does is reduces the stress of the parent. The parents like to be there. They're always worried. I would always recommend, if you're comfortable with whatever procedure you're doing, don't tell people you can't be here for this. We have something to hide. If something goes wrong and you would not let them see the procedure, trust me, they know you did something wrong even if you didn't. And we don't know. There's no way to tell if it makes the babies feel better, but it makes the parents feel better, so you should let them stay in the room. And these abstracts confirm it really didn't raise the anxiety of the provider. The providers are pretty used to it. And I would really extend this to not just urethral catheterization, IV starts in babies, lab draws, LPs for anybody. I would make sure that for LPs that the family sits on the other side, put them in the stands on the observatory side. Don't have them critiquing your technique on the back over here. What are you doing over there? Just go over there. Hold their hand on the other side. But let them stay for the LP. All right. Can visual inspection of the urine identify urinary tract infection? Can you hold this up to the light, ultraviolet light, with maybe a piece of paper behind it or something to really see if you can really tell if it's cloudy or not? Does that really change the picture here? Can you predict it? What do you think? Does anyone ever do that? How about taste? No, probably not. Probably not. But, if you look at this with visual inspection, it's not bad. 159 urine samples in Abstract 25, sensitivity of 90%, specificity of 82% by eyeballing this. And you know what? They said that oftentimes this was actually better than dipstick sensitivities, which are as low as 28%. So what they did was, again, they put it in a red top. They wanted you to see if you could read the print behind something holding up to ultraviolet light. 18% of all comers had positive cultures, but a third, so more than the positive cultures, a third of the specimens were cloudy. So maybe some of them had like an amorphous substance or something and nothing showed up in the urine, but they picked up all of the people who actually had an infection. But you're going to have some false positives by doing that. But kind of interesting. All right, how well do dipstick tests perform in pediatric urinalysis? Abstracts 26 through 34, and I'll summarize this with just a couple things. And they don't work very well. Dipsticks are our mainstay oftentimes, and they're not great. Let's take a look at this graph or this table. Sensitivity of leukocyte esterase, 76%. We are looking for a screening test. A sensitivity of 76% is not good enough. Nitrite, 52 to 83%, not enough. You add the two together, 80 to 98%. Maybe if you get to the 98%, it's good enough. Microscopy, 71 to 86%. But when you add the three, leukocyte esterase, nitrite, and your microscopic view, that's 100% specific, 100% sensitive. So that's what we need to be looking at. Do they have white cells? Is there nitrite? Is there leukocyte esterase? You know they have a UTI if they have those three things. And we'll skip down to Abstract 34, which was a meta-analysis of screening tests for UTIs, looking at 26 publications, and they looked at likelihood ratios. How about the gram stain? The likelihood ratio of the positive gram stain, 18.5. Good test. And how about leukocyte esterase plus nitrite, 12.6. They graded it a little bit better here, but gram stain is definitely great. And that may not take too long to get. On those cases you're really worried about, a gram stain is of great value. Now, what is an enhanced urinalysis, and is there any value to it? Is anyone doing enhanced urinalyses? What they use is a hemocytometer, the same type of thing they look at CSF with, and they're trying to find out how many white cells are in a cubic millimeter of urine, and a positive test is basically greater than 10 white cells per cubic millimeter. And abstract 35, they did standard versus enhanced, so 5 white cells per high power field versus 10 white cells per cubic millimeter. And sensitivity was compared to positive predictive value. Standard 65.6 versus 80.8. And the enhanced bumped the sensitivity up to 84.5% and the positive predictive value up to 93.1. This is a pretty good test, actually. They do combine this with a gram stain, just so you know. So is actually the hemocytometer the answer? I'm not so sure that it is. But they combine it with a gram stain, which makes it that much more sensitive. Abstract 36, 344 kids, less than 2 months of age, with a temp of 38 or greater. 25 UTIs were identified. 24 of the 25 were identified by an enhanced urinalysis. So I think you need to ask your lab, do we have this available to us? Are urine cultures ever needed in children with a negative enhanced urinalysis? Well, what they said in abstract 37 was it's a really good test. If you add one other component to it, then the specificity goes up from 95% to 99%. Add the presence of bacteria and the specificity goes to 99%. And they're saying here that maybe you don't need a culture in them unless they have a history of urinary tract problems or they are receiving from antibiotics presumptively to treat an infection. In those two subcategories, you might want to do that. But otherwise, if you add bacteria to this, you've got your answer, and a culture isn't going to add much to the picture. Now, here's an interesting abstract, 38. Can fever produce pyuria in children? So we've got a febrile child, febrile infant, and we're worried about UTI knowing that's the #1 likely cause of a serious bacterial infection, and we're going to look for white cells in the urine. 70 febrile and 87 afebrile children without UTIs, based on their culture, were evaluated. A moderate pyuria was noted in 43% of the febrile children. So we know just by having a fever in that age group, you can have white cells in your urine. It can just happen. So do not rely on the white cells alone. Do office-based practitioners perform pediatric urine cultures? It's very similar to the other abstract we did regarding the American Academy of Pediatrics guideline, and the answer is really no. They don't follow this guideline either. Less than 2 years old, in the patients only less than 2 years old, only 13% of practitioners routinely did this in febrile pediatric patients at risk for UTI. 3,066 kids less than 3 months of age had a urine dipstick or a culture performed in 58% of them, and that was it. So they don't follow that guideline either. But remember to be a little bit careful. Sometimes when we extrapolate outside practice or non-emergency department practice to the ED, we run into trouble. The good analogy is, have you ever called the family doc or the internist and say, I've got somebody with chest pain, and I think they need to be admitted. You explain the case, and they come back and say, you know what, if that patient presented to my office, I would never admit them. And your response should be, if you look at the data, the patients that present to your office are different than the patients that present to the ED. I treat a sicker subset of patients. And so maybe the same concept is true for this. Maybe they are treating a little less sick patient, but overall, we shouldn't back away because they're not following it. We shouldn't stop following it because the patients that select themselves out to come to the ED for their illnesses are probably sicker, and we will miss more illness if we don't follow these guidelines. All right, that's it for urine. So if you have any questions, I'll be happy to answer those.